Good. Okay. Welcome everyone to this meeting of the Leicestershire Health and Wellbeing Board. My name is Michael Squires and I'm the new Cabinet Lead Member for Health at Leicestershire County Council and the new Chair of this board. This meeting is being broadcast live via YouTube and it will be archived so you can view it afterwards. Please turn your microphone on when speaking and don't forget to turn it off afterwards. Moving on to apologies. We've received apologies from Jean Knight, LPT, so Glyn Edwards will be substituting for Jean. Fiona Barber, Health Watch, has also given apologies, so Hardip Chauhan is substituting for Fiona. Our District Council reps are Councillor Cherry Cashmore and Councillor Jerry Kaufman, are unfortunately not available to attend today. John Sinnott has also given apologies. And agenda item number 1, appointment of the chairman. This item is just to formally note that I'm now chair of the board. Thank you very much. Agenda item number 2, pages 3 to 11. I propose that the minutes of the meeting held on the 27th February 2025 are taken as read, confirmed and signed. All in agreement? Okay. Urgent items. There are no urgent items at present. Moving on to declarations of interest. I need to declare an interest in all substantive agenda items due to my employment with LPT. I do not believe that any of the agenda items today are sufficient to relate to my employment, require me to leave the room, but going forward in my role, I will give consideration to whether I will need to withdraw from decision-making processes. Do any of the members have any interest which they wish to declare in respect of items on this agenda? Okay. Agenda item number 5. Next we have my position statement. At the Leicestershire County Council election on the 1st of May 2025, Reform UK was the party with the most seats and Reform have formed a minority administration. The membership of the Council's Cabinet was confirmed at the County Council meeting on the 14th of May 2025. The new Cabinet Lead Member for Health is Michael Squires, me. The new Cabinet Lead Member for Adult Social Care is Mr. Joseph Bone, CC. And the new Cabinet Lead Member for Children and Families is Mr. Charles Pugsley, CC. All 3 members are entitled to places on the Health and Wellbeing Board. We also welcome Siobhan Peters, representing the Office of the Police and Crime Commissioner, to our first meeting of the board. Thank you for attending. The Integrated Care Board is entitled to have 5 representatives on the Health and Wellbeing Board overall, 2 clinical and 3 non-clinical. Due to changes in roles at the ICB, this is the last meeting that Dr. Nikhil Mahatma will be attending as the ICB clinical rep. Right, okay. Thank you for attending. Dr. Mahatma is thanked for his contributions to the board over the last year. Consideration is now being given to who at the ICB would be the most appropriate person to replace Dr. Mahatma on the board. It was recently announced that starting from the 1st of July 2025, Toby Sanders, Chief Executive of Northamptonshire ICB, will take on the role of Interim CEO for Leicester, Leicestershire and Rutland ICB, in addition to his current responsibilities. Toby Sanders will be invited to attend future Health and Wellbeing Board meetings as an ICB representative. Finally, it has been confirmed that Councillor Cheryl Cashmore, is Cheryl here today? No? Okay. And Councillor Jeffrey Kaufman, Oby and Wigston District Council, will continue as the elected member representatives from district and borough councils. Copies have been emailed to you and a version is also published on the council's website. Given that I'm new to this role, the position statement provides a general update about the health and care issues rather than focusing on the work of the Cabinet Lead for Health. Do any members have any questions? Okay. Item 5 on the agenda is the NHS transformation update. This report provides an update on the changes to NHS structures which are taking place. To present this report, we have Rachel Dewar, Assistant Director, Integration and Transformation, ICB.
Thank you, Chair. Good afternoon, everybody. I have provided a paper, which I will take as read. This paper has been shared across all of our local stakeholders and just gives an outline of the changes that are happening as part of the NHS transformation and what that means in terms of where we're at. The paper is much more sketchy than a paper I would usually present, but that's because of the level of information that's actually available to us at the moment. What we do know is that we will be working through a clustering arrangement with Northamptonshire, and we are in early stages of talking to Northamptonshire about what that is and what that will look like. Very much this is being driven through the national agenda. There's currently 42 ICBs across the country, and the plan is to reduce the number of ICBs overall as part of the changes to the NHS, but also to very much focus the ICBs on strategic commissioning, and much more weight is being placed on the role of strategic commissioning. So the paper, I hope, has the information that we are able to provide at the moment. This will continue to come out centrally from our comms team. So as we get made aware of the changes in more detail, we will absolutely share those with all partners across the system.
Thank you very much. Item 6. Oh, sorry. Questions. Yes. Any questions? Yes, go ahead.
Good afternoon, Kevin Ankimani from Voluntary Action Leicestershire. Rachel, it's just a plea just to say that I know obviously there's a lot still going on internally for you guys to understand. When you get to the decision about budgets and there may be potential cuts, contracts needing to be stopped and stuff, if we could be given the heads up as early as possible as the voluntary sector, because if there are going to be organisations that might, worst case scenario, be told that contract's going to go, it gives us more chance at VAL to then work with those organisations to try and secure future funding for them.
Yeah, absolutely. And I recognise the anxiety across the system about what the changes are and what the changes might mean, both internally in the ICB and externally. As we are working through any form of changes, we will make sure that all partners, especially and including the voluntary sector, who we know are very much our eyes and ears out there in the community, will be absolutely informed of those.
Thank you. Could you just remind me which organisation you represent?
Yeah, I'm the Chief Executive of Voluntary Action Leicestershire.
And I understand we have a question this side.
Hi, I'm Jane Moore. I'm the Director of Children's Services. Similar question, really. I guess it would be really helpful to know that we are going to be kind of working together through some of the changes. I'm obviously particularly concerned around some of the inference around send and safeguarding. It would be really helpful to really early on work together to understand what, I know you can't share what that looks like already, but actually to work together on what that looks like going forward is really important. But also how assured we can be over the interim period as well that things don't shift unnecessarily, particularly around some of those areas.
Yeah, absolutely. I mean, no sudden decisions or changes will be made during the interim period. One of the things that we absolutely need to work through, and it's described in the paper which I attached as an appendices to this, is what is going to stay with the ICB and what is going to move over to more of a provider collaborative kind of delivery model. And one of the things that we will need to work through with that is are our collaboratives strong enough at the moment to actually take those responsibilities? How are we going to hand those over in a responsible way? And how are we going to make sure that we have the appropriate resource in those places to be able to manage the ask?
Any other questions? Yes, go ahead.
Hi everyone, I'm Hardeep Chauhan, also from Voluntary Action Leicestershire. We're the contract holder for Healthwatch Leicestershire, and I'm representing Healthwatch today. My question for you is just around, do you have any information on any impact on accessing services or wait times? I know what you're going to say, not yet, but just a plea again, just to make sure that Healthwatch is involved with that so that we can communicate that to patients and the public.
Yeah, so as the paper states, this isn't a change that we would envisage the patients actually see or feel a particular difference. This is much more around the workings of the ICB and the manner in which decisions and ownership of those decisions and enaction of those decisions are made and taken. So from a patient perspective, we would absolutely hope that there wouldn't be anything that feels different to them. And I think it's just about how we work together to make sure that that is the outcome.
And Mike, I understand you've got a question.
Yeah, thank you, Chair. Rachel, I know you said you can't give us detail, but I'm going to ask, can you give us detail? In terms of next, go on, have a go. Let's do the kind of timescales then, because things have got to move very, very quickly. And I know you can't say what's going to happen and we need to work it out. Have you got an idea about what the key milestones would be? Because like Jane, I really want to have those kind of early conversations, particularly for me. And it's kind of two bits, isn't there? The bits where the national blueprint has signalled that things have got to shift, which then caused a bit of worry on our side. But even the core functions of ICBs in the clustering arrangements, I'm looking at needs analysis. I guess my fear is we get sucked into a kind of centralised LNR-wide conversation when actually I think a lot of that's already in Leicestershire, because it is things like the work of this board, the Joint Strategic Needs Assessment. So how do we have an early conversation which doesn't end up going down one path where we might have said from the start, actually, do you want to think about doing it that way?
Yeah, absolutely. So the only milestone I can really give you at the moment is that on the 30th of this month, so tomorrow, ICBs have been asked to submit a template which was sent out by the national team outlining their plans and how they expect to achieve the savings which are expected to be achieved and how they expect to progress with their clustering arrangements. So that template has been completed. It hasn't been shared with the wider ICB yet because there are details in there which, until we get some sort of sense about whether that's going to be approved or accepted, what we don't want to do is share information that might end up not being the correct information. So that's the key deadline. We expect that we will get some information around voluntary redundancy schemes and other schemes in the coming weeks. But we haven't been given any deadlines for those. And I think the expectation is that we will start to move quite rapidly into some of the changes over Q2 and Q3 of this year.
John Wilson.
Thank you. John Wilson, Director of Adults at Leicestershire County Council. Thanks, Rachel, and appreciate this is a really difficult time for colleagues in the ICB and really unsettling. And there will inevitably be quite a lot of focus on internal kind of matters, as you'd expect. But equally, we do and have over the last few years built up some fantastic partnership arrangements locally. And obviously we are concerned that a much bigger, broader ICB may be more distant, and some of those partnerships and relationships may be under some degree of strain. And as it notes in the report, a number of functions may need to transfer to partners or providers. Talked about subject to legislative changes. My guess is that given the pace of change that NHS England want to work to some of those changes are going to take place ahead of legislative changes, because we're simply not going to get those in place in the next 2 quarters. So there is a degree of risk in all of that, and particularly as we may be asked as local authorities or other service providers to pick up responsibilities for which we don't have a statutory basis and for which we don't have a power to deliver. So it would be really helpful if we could work together very closely on making sure we mitigate any risk that might be entailed in that.
Yeah, absolutely. And I think what is reassuring within all of the plans, place and neighbourhood, is still very much seen as a focus, and very much seen as a really important part of our health and care structures, and the acknowledgement of us continuing to work in partnership and improve that partnership working actually is really strongly within there. The next paper that I'm going to talk about is around the neighbourhood models of care and how we're going to kind of ground that ahead of the changes so that we can be really confident that at place and neighbourhood we're still absolutely acknowledging and working in partnership across the whole spectrum of healthcare and the wider voluntary sector and asset-based communities.
Any further questions? Yes, I can't see your nameplate there, but go ahead.
Yeah, sorry, I'm stepping in for Simon Pizzi today on behalf of UHL. So I'm Ashley Epps. So yes, I think similarly to some of the points, I'm sure you won't be able to provide necessarily the answer, but I think we're kind of seeking clarity on the details as well. So in terms of things like if these functions transfer over, what kind of finances, resources would be attached? Because obviously across the NHS, there's all these efficiencies going on. So that's kind of one of our main queries, I suppose. And also things like the neighbourhood provider sort of group, we're not yet sure, I don't know if you are, whether like which organisations will be in that kind of group as well. Thanks.
Yeah, again, a little bit too early to give you that level of detail, but all I can give at this stage is an assurance that we will share the information as soon as we have it available to us.
Rachel, do you anticipate that you might have the answers to some of these questions by the next Health and Wellbeing Board meeting? I appreciate you don't have the detail now, but will you by September?
The pace is moving really quickly. So yeah, I'm sure that we will have much more clarity over the coming weeks. And I think it will be really important to communicate that in between the health and wellbeing boards as well, because I think the pace is going to be faster than kind of giving an update in September. So I think what we need to consider is how we're going to make sure that we have that really robust communication, and how we make sure that we're keeping all of our stakeholders, all of our partners, all of our friends and colleagues involved in the work that's happening. And as soon as we find out the information, we will absolutely be sharing that.
Thank you. I propose that the information provided in the report be noted. All in agreement? Thank you. Agenda item number 6 is the Neighbourhood Health Programme. This report provides information on progress made to date with implementing the Neighbourhood Health Programme in Leicestershire. Rachel Dewar will again present this report.
You're going to be sick of tired of me by the end of this meeting today. So again, I've provided a paper which is a board paper that talks about the neighbourhood models of care and the work that we are doing to progress around that. In summary, what I would suggest is I think we have a really good grounding in Leicestershire in terms of the neighbourhood working. I think we've got some really good examples of where we have worked in partnership to improve outcomes for our patients. So an example of that would be the work that we've done with our reablement team and integrating with our therapy services and our district nursing services, and how that has helped us. There are 6 key elements to the neighbourhood model of care, which range from the population health management to community health services to the model GP framework to integrated care and our home first approach. So they are the key areas that we are focusing on at the minute in terms of understanding where we are at in terms of this model of care. I think what's really important to say is I think a lot of the documentation around the neighbourhood model of care has been quite health heavy in terms of the literature around it. So I think what's really important to say is this isn't around shifting a medical model into the community. This is absolutely about us working much more closely with the people that understand those populations the best. And our population health management tools will help us with some of that. But it's really important that as we think about growing that neighbourhood model, we offer our people something that is going to meet their needs from a health perspective, but also from those wider determinants perspective. We are holding a workshop on Tuesday, and invitations are flying around all over the place. So we are hoping to have a really sound representation in that space where we will work through from an LLR perspective, but also have an opportunity to talk about our 3 places individually, what this model means for us and how we're going to develop this model in a way that's going to make a meaningful change to our people. I think the paper describes that in year 1, we absolutely recognise that our focus is on our burning platform around the number of attendances that we are having in our ED department, and it is quite UEC heavy, urgent and emergency care heavy, I think, in year 1. What we're absolutely clear about is that's not what we want the future of this model to be. So the workshop will be focusing on our 5 and 10-year plan and how we really help all the way through from primary prevention all the way through to supporting our people that have long-term conditions, multiple long-term conditions, and frailty, in terms of making sure that we have a really robust and easy to access community offer, which will support those people, and that also the care planning that we do with those people is robust and meaningful in terms of them taking ownership of their own condition, but also where we're saying this is the pathway that needs to be accessed, that pathway is available to them. So the paper is much more strategic and at a higher level than perhaps I'm talking through, but I think it's important to give that context around what we want to achieve through implementing this model and the difference that we hope it will make. The workshop on Tuesday will be really crucial in terms of setting out our longer term vision. It will also be really important in identifying some of the gaps and the challenges that we have at the moment and how we're going to overcome those.
Thank you. Do we have any questions? Okay. Kevin. Oh, sorry, I didn't see you there, Kevin. Go ahead.
Thanks, Chair. It's a bit of a plea again. Sorry, I know you're saying people get fed up hearing you're going to get fed up with me saying the same things I always say at these meetings, which is it's great what's been put on there, and it's great that we're talking about getting the patient voice there, but the voluntary sector really needs to be fed into an integral part of this neighbourhood sort of programme work going forward. I mean, to put it into perspective, we've at VAL got a database of 5,800 organisations across the county. That's roughly just about over 4,000. 85% of those are your small grassroots groups that really do need to be linked in. It's not saying they're going to be able to deliver services around here, but they'll have service users, they'll have individuals that will come to them that probably need to know and could be signposted to whatever is put on there. So I think it's just a plea to say, can we have a chat? Thank you.
We absolutely can, Kevin. And I'm really hoping that we can get really strong attendance also at the workshop so that we can continue this conversation. I think for me, what is fundamental within this model is we know that people access healthcare because of wider determinants rather than their health need predominantly. So we know that isolation plays a huge part in this. We know that depression plays a huge part in this. We know that carer strain plays a huge part in this. And all of those areas are areas that absolutely we rely on the voluntary sector and the asset-based community services to really support our people with. So yeah, recognise how integral you are to that.
Thank you. I have one question. Could it be looked at in terms of integrating some of those services into our family hubs, for example, family hubs and neighbourhood hubs, to potentially reduce costs and improve services by collaborating a bit more?
Yeah, we'll absolutely be exploring every opportunity to co-locate services. We've seen evidence time and time again that actually the best work happens when you're making a cup of coffee and you just happen to chat to somebody from a different service who happens to be thinking about a similar issue to you. We've seen that time and time again, and when we have been able to co-locate services, we've seen some real advantages to that. Of course, there's going to be limitations around estates and all of the usual challenges that we have, but we will absolutely be exploring every opportunity to do this.
Thank you. Yes, Hardeep Chauhan, please.
Thank you. So I had made some notes, Rachel, about co-production and engaging with the public, but I've had an email since I made those notes from our chair of Healthwatch, Harsh Architecture, and I know that she's been in contact with you and you've got some ideas around engaging with this. So I just wanted to acknowledge that really and say thank you.
Thank you. Any other questions? So I propose that the board notes the progress made thus far and supports the direction of travel outlined in the report. All in agreement? Thank you. Our next report is the resilience strategy, which is on pages 49 to 67. This report provides an overview of the LLR Community Resilience Strategy 24 to 28 and delivery plan. Christy. Welcome. Yeah, that's fine. So this report will be introduced by Rachna Vyas. Oh, she's not here. Oh, you won't be doing that then.
You've got me again, I'm afraid, to introduce. Hi.
Go ahead.
So the Local Resilience Forum supports any system-wide responses to incidents, floods, civil disorder, health demand, terrorism, etc. And a subgroup of that is the People and Communities Forum. The exec lead for that is Rachna, supported by Rachel and Christy. Rachel and Christy lead this as part of the national ask was for systems to work with their communities so they're better prepared. So the resilience strategy is the first step in that engagement with the voluntary sector and individual community groups, and recognise that it's a start and we will build with the help of each part of LLR as we learn from and with our communities. So I'm going to hand over now to Rachel and Christy to present their report. Thank you.
Thank you very much, Rachel. I thought I'd have to do all that bit myself when I was told she wasn't coming. So thank you. Thank you, Chair, and thank you, everyone. I'm Christy Bull. I'm the Communities Lead here at Leicestershire County Council's Chief Exec's Department. And I'll let Rachel introduce herself too.
Hi, I'm Rachel Payne. I'm a Senior Emergency Response Officer with the British Red Cross. So I work with a team of staff and volunteers that manage emergencies and crises in the UK. And as part of that role, I co-chair the People and Communities Board with Christy.
Rather than Rachel, I thought I would take a couple of minutes to go through the Coven report. In your items, you also have the Community Resilience Strategy, CRS, from now on, and also the delivery plan. So I know you've had a brief introduction to some of the work of the LLR prepared, but I will go over it with you. And also what I'd like the Health and Wellbeing Board to consider is to raise awareness within your organisations and networks, much as Rachel said, it's all of us. Identify activities and actions from your organisations that could be included in the delivery plan, which Rachel will come to. to work with LLR Prepared in supporting communities to plan for, respond to and recover from emergencies. And we've already heard about wider determinants, we've already heard about those things that affect people more, and emergencies will affect people more depending on their circumstances. So in paragraphs 4 to 6, we give you a little bit of the background around those resilience forums. They are part of the Civil Contingency Act, and it's made up of category 1 and 2 responders. There's a number of people in the room that are those category 1 and 2 responders, and also chair some of those important meetings. In the actual covering report, I explain what those are, so do have a look at that. And also it's currently chaired by the Chief Fire Officer, which is a little unusual because I think the Chief Constable has chaired that LRR executive for all the time we've had it. There was also the UK Government Resilience Framework published in December 2022, and it's based on the 3 principles of a developed and shared understanding of the civil contingency risks. So they're laid out, and also on LLR Prepared, those risks that affect us all as LLR. Prevention rather than cure, which fits with the emphasis of this kind of work, and also emphasis on preparation and prevention. And the main one here is resilience is a whole of society endeavour. It's not just down to somebody or somebody else or some other group. In paragraphs 7 to 10, we cover what community resilience is. And in our definition, it is the ability of communities and individuals to harness resources and expertise to help prepare themselves for, respond to and recover from emergencies. The Community Resilience Strategy, CRS, aligns with the wider work of the LLR Prepared and is owned by the executive, of which Rachna is our representative, as you said. It's overseen by us too in the PCOM group, and we're actually extending that to be recovery group. HARDIP does attend from the voluntary sector. There are other people, lots of other attendees from across all areas, so we are part of that work. The CRS advocates for an approach that is based on the approaches of social action and community development. We've heard something about asset-based work as well. So that's building on what's strong and not what's wrong in a community and going with those people that can help themselves and others. Paragraphs 12 to 14 explains the what of the strategy and enabling and how through the delivery of the plan, we will achieve those things. I think importantly, it's to get to the point of understanding that, as we say in paragraph 17 and 18, there is increasing demand and there are less resources. And by helping people to help themselves and others, we hope that that affects individuals, communities and those public services to respond to and recover from those emergencies. And we've already said it in that neighbourhood work and partnership working. So it is in collaboration with communities. It is about what HARDIP said about, co-production, working with, so that people are more prepared, resilient and healthier. So I'll just pass on to Rachel for the next part.
Thanks, Christy. So in your pack, you will have seen the delivery plan for the community resilience strategy. So the delivery plan essentially takes the objectives from the plan and cross-cuts them with the resilience standards. So there's a number of resilience standards across the UK. They're not statutory requirements, but most resilience forums are looking to achieve those. And from that, we've created a number of actions which fit in with both of those aspects of the work. I think the major piece of work that we've done recently is the work with the voluntary sector responders. So there's a draft plan now in place that sets to coordinate voluntary sector responders. So we're all working together as opposed to each organisation do their own little bit of things. So by working collaboratively, those organisations are able to help in a much more structured way and even to help each other out in what they're delivering. We've also got some funding for businesses to develop their community resilience. And last year we were part of a project with the British Red Cross around community resilience. And we were encouraging predominantly parish councils to create their own very local specific plans. So understanding what resource that they've got in their community that could be utilised in emergency because at the end of the day, they're the ones that are there in it at that time, and it could be some time before local authority and emergency services are able to get to them. And obviously they'll be prioritised according to need. So it may be that a community is on their own for a period of time. So it's supporting those communities to understand what they can do to help themselves, essentially.
Thank you. Any questions? Yes, Kevin, go ahead.
Hello. Thanks for this. It's really great. It's really good to see it come to life, because I know we've been talking about this since the pandemic, and I think we went through as a voluntary sector to try and get something there, making it wider than just a health pandemic about, you know, the potential floods, the other issues that could happen to some local communities. I suppose my question really, and it might also then be something that maybe Abby or Mike might be able to pick up, is we're obviously refreshing the joint health and wellbeing strategy. There is in that elements of cross-cutting themes, and there's a bit in there at the moment around the pandemic, which I think from the groups I've been attending, we have been saying, well, actually, we probably need to take out references to COVID-19. It's probably more about a wider resilience approach. Have there been discussions yet? If not, I think there should be, about how that fits in. Because if not, I think we're going to end up potentially with this over here, great piece of work, refreshed health and wellbeing strategy over here, and then not connecting. I'm not saying it's got to be like led by KPIs or targets, but I think there needs to be some kind of recognition between the two.
I can answer that. I've not had a conversation with you yet.
Yes, but we could do, is the answer, isn't it? I think it's a good point, and I was thinking similar, slightly different, in as much as here is a community resilience strategy, gets members of the community to think about how they support each other. Do we also then need, as a health and wellbeing board, and we can take that forward, almost think about, is there any specific health things? I was thinking obviously like workaround for people to get evacuated from their homes and they need access to the medication. So as part of maybe not just replicating what's in here in our health and wellbeing strategy, is the piece of work to go, yeah, great, this is here. What do we need to do specifically that's for kind of vulnerable cohorts to do with health? But
you may also recall, Mike, that we were the soothsayers of a wet summer when you did a webinar around extreme heat. So that is still available. So you, if you remember, so there's the extreme heat issues, the cold, but yeah, if you, we still have that recorded because we've done some of those wider conversations.
so, sorry to butt in. So going back to it then, you know, is that an action like take forward all that? I mean, I don't want to make work for myself, but people in my team, there's almost like a health action plan which picks up on some of the health hazards related to health or flooding or bits around vulnerable people and the rest of it.
Yeah.
Sorry, and would that then be through this group or the local health resilience forum, local health resilience partnership, or
there is a working group, I think, isn't there, as part of the around vulnerability, which I think would be really useful to link into.
Any further questions? Yes, Rachel, go ahead.
Yeah, thank you. A really great presentation and some great work happening. I think what I just want to acknowledge is we have had the floods recently and lots of other opportunities to test ourselves in terms of our resilience work and how well that works. And I've seen some really great examples actually of very quickly being able to identify the most vulnerable people living in that area, people with urgent health needs, people with medication needs, and people who are on the lists of visiting services as well, who are not going to be able to access those patients. So I think we've got a really great foundation for that, but I do think that there's always opportunities to strengthen and work on that. We're in the really early stages of this work, and I feel really positive that actually it's going to give us that additional robustness to our resilience plans, and huge appreciation for everybody that's putting the time into doing the work on this.
Any further questions? Sorry, I couldn't remember your name. Rachel. Yeah, I've just got a question. So you mentioned communities responding to emergencies with their available resources before the emergency services arrive. What emergencies might you anticipate, and what resources do you feel that they need, and what do they have? Sorry, that's a lot of questions.
So it could be anything really. It could be that there's minor flooding in a village and elsewhere it's worse, so that area is prioritised by the local authority and the emergency services. But it might be having an understanding of things like there's a village hall or there's a scout hut or something like that where people could evacuate to or have a meeting place, or it might be the village pub. Farmer so and so might have a tractor that he can clear an area with. It's all those kind of really low level things, but that would have an impact on a community straight away. Flood wardens, yeah, flood wardens. So a lot of local areas now have got flood wardens, and there's regular recruitment of those. So they'll have a better understanding of the flood risks in their area and are sharing messages on social media, and then will feed back into the local resilience duty officer, which gives a better picture.
The work with the that we did last September through to November was about writing community response plans, and there's something that happen in a number of areas, and it's about considering the risks locally as well. So it's about identifying, as Rachel said, what resources you might have locally. Do you have somewhere that someone can get road impassable because they don't have road closure signs? That's one of the major things. Or about not entering floodwater, or about a local WhatsApp group that says, hang on a minute, this is happening, do we need to know this? One of the things that happened in Ratby, where I'm from, Ratby Kirby Muxlow gas outage, which Jane was the chair for the main on, that was about getting some key identified people locally, said, here's a church hall, here's this, I know where someone is, oh, they're on holiday. So it's that getting that local knowledge and people coming forward, but actually having that before an emergency, because people are actually very good in an emergency and they really try to help. But if we can have some things before, if there's a major power outage, if there's something like that, it's that local that will help us.
And Mike, go ahead.
Yeah, just a little one. Does that pick up as well on the role of members as community champions? I mean, it's often patch members that know people in their community that can do that.
Okay, and Hardeep Chauhan.
Yeah, I just wanted to add on to that, Chair, because I do sit on the group, so I might be slightly biased. But it is a group that is worked really well collaboratively, and we do share intelligence from our VCSE sector and any public or patient involvement, anything to do with any local intelligence or local community work that's happening or resources that are available, and we do pass that through to both Christy and Rachel and the group. So I know that that intelligence works really well, and we're always in support of that. So just wanted to add my little bit in, if you don't mind.
Thank you. So if there's no further questions, okay. So I propose that the board agrees to raise awareness of the CRS strategy 24 to 25 with members, organisations and networks, to identify activities and actions from members' organisations that could be included in the delivery plan, and to work with LLR Prepared in supporting communities to plan for, respond to and recover from emergencies. All in agreement? Thank you. Item 8 on the agenda is the pharmaceutical needs assessment, pages 69 to 176. Hello, Hannah. This report provides an update on the work undertaken to produce the draft pharmaceutical needs assessment 2025 and seeks the board's approval to consult on the draft document. Dr. Hannah Blackledge, Senior Intelligence Manager, Leicestershire County Council, will present this report, and she's joining us online.
Thank you, Chair, and I'm really sorry I can't join you in person today. In the pack, you will have the board paper, the attachment, which is the main P&A report, and a timeline for the whole project, which I'll refer to later. The appendix. There is also a pretty hefty appendix online. There is a reference in the document to that there as well. So the purpose of today is really to effectively seek the approval of the board for this draft. It's a pre-consultation draft of the P&A. We'll try to be skim a bit through the detail because there is a lot in this document, but just give you a quick brief what's included in the report, a little bit of context, present, sort of talk about what's in the main chapters, what are the sort of emerging themes, and what happens next, because the publication is due by the 1st of October. So I'll outline what happens next. Basically, for those who know, this is a statute document which sort of comes back to each Health and Wellbeing Board every 3 years. For those of you who don't, so for whom it's for the first time, just quickly to say that P&A, pharmaceutical needs assessment, is a statutory document that has to be produced by the Health and Wellbeing Board every 3 years. It's very much dictated by the effectively by a national guidance. So very the contents of it is really up to the board, but very much the structure of it is predetermined, dictated by what's expected of it, if that makes sense. So, but generally the P&As are done to help the NHS England and ICB in the commissioning of in their commissioning decisions regarding the pharmaceutical services, and they do particularly in situations where new pharmacies are to be opened, merged, and in these circumstances, effectively, it is about trying to match the current provision of service to the need in the population. The whole process is over. There is a reference group which is LLR wide. The reason for it is because it is a commissioning patch for pharmaceutical services, and so although we do have a report which looks slightly differently for each of the three health and wellbeing boards, the general approach and the contents are similar. This presentation is just about Leicestershire. For the purpose of the P&A, the localities have been defined as districts. And it's probably worth mentioning at this stage that there is a ever evolving picture at the moment. We did have a new agreement, community pharmacy contractual framework agreement in this spring, which applies to this financial year and the next financial year, and very much revolving around the changing role of pharmacy services, community pharmacy within the primary care offer for the population. So that there are some changes, that there has been a financial uplift for pharmacies, plus changes in how services or what services are delivered. So we have submitted a project plan back in, I think, September last year, and that has been agreed by the board. Since then, the reference group has met several times and steered the process. And at this stage, we have a draft which contains a lot of chapters about population needs for the services, the provision services, and also preliminary results of our community engagement, the first part of community engagement, with 2 surveys. One survey was public, and one survey of pharmacies. And I will touch upon it in a bit more detail in a second. What still awaits us is this over the summer, the 90-day consultation. So we look in the main report, we look at demography, local health needs, very much a sort of broad public health profile of both Leicestershire as a whole and individual districts. We also are trying to estimate the future needs, both through projected demographic changes, also housing plans for each of the districts. And the bottom line is probably not a surprise that both in terms of morbidity and multimorbidity, that is likely to be increasing needs over the next 3 years for the population. And you will probably have more detail in the actual document. We look in details into the main part of it is the access to services from the point of view of numbers and locations of community pharmacies and dispensing GPs. We look at cross-border provision where it's appropriate, particularly at the sort of edges of Leicestershire. Opening times, access by walking, travelling time to pharmacies also analysed. We look at equity by deprivation, age, rurality, and there is a big section on advanced services, particularly the ones to mention is Pharmacy First, which is evolving this year. Advanced enhanced service and locally commissioned services in more detail. The previous versions, the previous editions of this, the last one was in 2022. Editions of this document looked at the more sort of static picture because we have an evolving picture around advanced services. We sort of looked this time round in detail at time trends in provision across the Leicestershire and individual districts. So we also conducted, as I said, these 2 surveys. There was a quite good response to the public survey this year, with 739 respondents in Leicestershire alone. So there are preliminary results of that summarised, although the public survey just closed last month, so there is still a bit of analysis to be done. The professional survey didn't have a good response so far, so it is still open until probably through the through summer, at least probably till the end of July. So there's only been 44 pharmacies responding so far across LLR and 22 in Leicestershire. What emerged so far is that in the public survey there was a reasonably good satisfaction with services and what's interesting, definite preference to the brick and mortar pharmacies rather than any online options. But there is more detail, but these are only preliminary summaries of those surveys. We analyze gaps in services and haven't, in terms of sort of access to necessary services, we would not find particular gaps. There is some indication of a geographical gap in the east of the county through Melton and Hinckley in particular, but there is a cross-border provision from Rutland pharmacies. But that's geographically, in terms of people not having access, we've not found a big gap. There is some difficulty accessing pharmacies on Sunday nights, with just two pharmacies across Leicestershire being open at that time. But generally it's not been, there is no major issue unless we hear otherwise through consultation. In terms of services, I mean, the P&A requests, there is a legal obligation to have a certain number of statements in those P&As, which is the board satisfied that on the necessary services there is no gaps in any necessary services, including particularly essential services, whether the advanced services are available to all, but also whether there are any services that could be provided and could provide a benefit but are not provided yet. So in terms of essential services, a very broad measure of that is number of pharmacies per population. And when we, including dispensing GPs in Leicestershire, that average, which is two pharmacies per 1,000 population, is effectively the same as the national average. So community pharmacies busy dispensing GPs are filling that gap where the access is worse for the to the community pharmacies. Most of Leicestershire community pharmacies provide advanced services. There's one exception, which is the smoking cessation, which is very specific services for adults leaving acute hospital care who did not have a chance to go through their full 12 weeks of smoking cessation program in hospital. So that's the only one, which is only a third of community pharmacies provide that. But other than that, most of services are provided. In terms of locally commissioned services, the new arrangements mean that the emergency hormonal contraception, which is currently locally commissioned, will be moved under the nationally commissioned advanced pharmacy contraception service from October this year. We only have one pharmacy providing urgent palliative care dispensing, and though looking at trends in dispensing, it's basically these trends have not changed over time, whether it was a few pharmacies providing it or just this one. So as far as we know, the H. pylori breath testing is only provided in Leicester and only for Leicester residents rather than Leicestershire residents. So moving on at this stage, the recommendations in the document are in draft, obviously still subject to whatever is recommended through the consultation. But there is clearly something to be said about being the population increases that are forecasted, which are clear, and increasing need over the next 3 years, and particularly in view of changes in the services provided by pharmacies. We would recommend that throughout the three-year period to the next P&A edition, the commissioners periodically update the Health and Wellbeing Board on the current location, whether there is any current gaps. An opening time for community pharmacies, whether there is any issues with equity of provision, and sort of monitor the activity in advanced services which are starting up now. There's been recruitment difficulties noted through several pharmacies through the current survey and known. So also it would be worth to have an update on whether these are whether the situation's better, basic, or worse throughout the next 3 years. So also would be, again, periodic update on any relevant local campaigns and relevant strategic developments in that area to the Health and Wellbeing Board. Again, so all these recommendations are subject to what we hear next from the through the engagement during the summer. So in terms of deadlines, what happens next, and sort of basically it's I think page 176 in your pack for your reference, are subject to the approval at this meeting. We will go ahead with the statutory consultation, which has now been organised from the 9th of June to the 10th of August. We will also complete an equity impact assessment during the summer, and the LLR reference group aims to agree the post-consultation drafts for all 3 areas on the 19th of August, and we will next bring the final document to the board on the 25th of September, to hopefully to publish it by the 1st of October. It will be probably up to the discussion of the reference group whether we need to bring the final document a bit earlier to ensure that it is actually published by the 1st of October, but hopefully not. That's really subject if there are any additional work or comments through the consultation period in summer. So happy to take any questions. Hope this sort of summarizes and makes reading of this long document a bit easier. Thank you very much.
Thank you. I can see we've got a question here. Go ahead.
Thanks, Chair. Thanks, Hannah, for the presentation. It was really useful, actually. I guess I just wanted to kind of ask, are we assured regarding the capacity and consistency of services that pharmacists are now delivering? So things like CPCS, the contraception. And I guess the only reason why I'm asking that is because I think moving forwards, the ICB will probably lean on the pharmacists to deliver further kind of pharmacy first services through same day access, potentially even the neighbourhood health hubs. I guess the question is, have we looked at that to make sure we're not inadvertently creating worsening health inequality and inequity, especially in the rural kind of areas?
Right. I mean, we've not discovered anywhere the only data we have of whether the pharmacy is actually signed up to deliver a service, and then the actual activity within the practice. So we've not that's definitely the majority of pharmacies are actually signed up, and there is an increasing for many services there is an increasing trend in activity. So probably hard for me to say whether there is a capacity. It's obviously partly this is a finance. Obviously, the new commissioning arrangements only kicked in this at the end of March, so I think that's probably partly why we had such problem with getting getting the pharmacists engaged in the survey, because they had a lot of other work to do at the time. But most of practices, I mean, there are detailed figures for each practice. Obviously, this is, as ever, usually the work of the P&A is sort of looking a little bit in the past as much as possible. This time round, we did look at sort of most recent months of activity. Even and in the past, the approach was just to look at the most recent completed financial year, which in our case would be 23-24 rather than more recent months. So I suspect it's very much for something to be considered in the commissioning round. I hope that helps.
Any other questions? Yes, Rachel.
Thanks, Hannah. Really helpful. Just a couple of questions from me. One is regarding the professional survey that you referenced. Is that professional survey for pharmacy professionals, or is it for broader professionals?
Yes, so it's usually, yes, it's aimed at pharmacies, and there's usually a representative of a pharmacy, whether it's different functions within different people within pharmacies, but somebody responds within a pharmacy on behalf of a pharmacy. So we take this as a response. So it's pharmacies rather than individuals within pharmacies.
Okay. So I guess my question is, how do other services feed into that? Do they do that through the public consultation? So thinking about primary care professionals, community professionals, and some of the opportunities that they envisage in terms of the pharmacy offer.
Very much through that will be rather through obviously there is an opportunity to impact the process through the reference group, because we do have a broad that's multidisciplinary. Both surveys are sort of again dictated by legislation. There is a public, and the responses in the surveys are expected from pharmacies and from the public. And again, the consultation period is another opportunity because that's a broad spectrum of organisations across the county.
Hardeep Chauhan, please.
Hi, Hannah. So just going back to your question, Rachel, about the surveys, we've had both surveys on our Healthwatch website. And I know that other professionals have probably been completing the public one. But just for future years, I think we should probably think about other ways of engaging with the professionals, or different ways of looking at that survey. But I know the public one, that some of the professionals have completed that as part of the public. And then, Chair, I've got two questions from Fiona Barber, who normally represents this group. She sent me them. The first question is, how does change to delivery impact on where pharmacies should be, for example, pharmacy first? And Hannah, her second question, sorry. What about new housing developments and Section 106 monies? Larger developments have longer planning, 5 to 10 years, and how does the PNA link into this? Thank you.
Yeah, so let me start with the second one. There is a piece of work actually ongoing, looking in more detail because we have the overall number of housing needs per district. The districts, unfortunately, the situation was up to now that the district was still in the process of planning, and we're not quite. The housing colleagues are still putting the numbers together, but we will have by the summer a sort of more detailed, sort of almost geographical distribution of where these housing developments will be, and the sort of expected number of houses and the expected number of people in there. At the end of the day, it's very much the whole. Obviously, there are issues with the fact that the housing is speeding up, but up to now, and it's sort of key because it's a public document. The colleagues in housing were very, very adamant that we have to, whatever we publish there, have to be absolutely agreed with the districts, because we can't publish any sort of, if it's an estimate, yes, but the moment we reference it as a housing plan for a district, it has to be absolutely confirmed. So this work is ongoing. What's in the document at the moment is the overall number of housing needs, but not yet the specific localities. So yeah, that was the second question. If you could remind me the first one.
Yes, of course. How does changes to delivery impact on where pharmacy should be, for example, pharmacy first?
Pharmacy first. So the majority of community pharmacies are actually signed up. So I don't think there's anything about pharmacy first that is specific. It's all based on effectively on the population and a population's travel time to pharmacies. So whatever pharmacies exist, and unless there is a gap, as I said, we've detected a gap geographically in the east of the county. There's always going to be obviously issues with access. Majority of people do travel by car when in rural areas, but there are there will be gaps in provision where public transport is concerned. Traditionally, this thing was looked at from sort of geographical point of view. So you do have a lot of maps with a lot of shading where the access is looks to be longer than preferred, but then we did look at from point of view of actually people resident within the area, and yes, there will always be problems where there's lack of public transport in rural areas, but that's for all services.
Thank you. Any other questions? Okay, I've got a question of myself. So a common issue is the out-of-hour dispensing of end-of-life medicines. What provision is there to ensure that those that are at the end of life can access urgent medicines? Because currently some community services rely on attending major hospitals or LUROS if there's an urgent unpredicted need, for example, if they're running out or there's a change of drug. I think you said there's only one current late night pharmacy for end of life care. So what provision is there to perhaps expand that or look at any gaps in the service?
I think I must admit I can't say very much historically, because from what I gather historically, there were more pharmacies providing it in the past. And we could only, within that report, we only judge it looking at sort of past trends, that the provision was actually very similar when there were several pharmacies providing it rather than one. It might be that commissioning colleagues might be better placed answering the question, but looking at time trends, there was a similar provision over the years. So it doesn't look like that this activity has increased or dropped over time. If that helps.
Thank you. Any further questions or comments? Okay. So I propose that the board notes the work undertaken to produce the draft P&A 2025, which has been developed in line with the findings of public and pharmacy surveys. Approves the draft P&A 2025, subject to any comments the board might have for statutory consultation, and notes that a further report will be considered by the board at its meeting in September 2025, detailing the outcome of the consultation and seeking approval of the final P&A 2025. All in agreement? Thank you. Next item on the agenda is the Adult and Community Strategy 2025-26, which is in pages 177 to 213. This report provides information relating to the refresh of the Adults and Community Strategy titled Delivering Wellbeing and Opportunity in Leicestershire 2025-2029. Stephen Shippey, Improvement Manager, Adults and Community, will present this report.
Thanks, Chair. I'll just give an introduction if that's okay before Stephen gives the detail. So this is a strategy which builds on our previous strategies over the course of the last 5 to 10 years. It is an opportunity for the Health and Wellbeing Board to comment on the draft before we ask the Council to approve the strategy. The strategy covers the whole of the Adults and Communities departments. That would include adult social care, culture services, libraries, museums, heritage, and adult learning services. And the principles upon which the strategy is based are largely those that we have, as I said, been looking to deliver over the last few years. The model of service which is in the report, which is a sort of the onion ring, you like, the model of sort of well-being, preventing, reducing, delaying, and then meeting need, is a well-rehearsed model and is taken from the Care Act, and is something that is well known both within the department in terms of the staff group, but also with wider partners. We've referenced the main aims of the strategy at paragraph 14 in the report, And just to note that we have produced the strategy as a co-produced piece with people who draw on care and support and with local providers and partners. I'll just now, if that's okay, ask Stephen just to run through the detail of the consultation that was undertaken in February, March of this year in preparation for approval of the strategy. Thanks, Stephen.
Thank you, John. Good afternoon, all. We commenced an 8-week public consultation from the 18th of February to the 14th of April, and respondents ranged from staff across our different service areas, care providers, we had carers, interested members of the public, health partners, charities, befriending services, and our Learning Disability Partnership Board self-advocates. To publicise the consultation, it was widely shared across social media, via local councils as well, with chief executives, our health partners via communications. It appeared in their 5 for Friday. We also updated our parish councils, newsletters, internal comments and separate briefings. And we prepared a video briefing for staff for them to view with the changes of the new strategy. We had 40 respondents, so over the course of the 8 weeks, and from the questions that were able to be graded, 80% or more of those responses were strongly agree or tend to agree. And each set of questions allowed for some responses, so some handwritten responses, and the general themes of those responses that we've taken into account from the consultation are to demonstrate our progress that we are going to make against the aims that we've put into our strategy and make sure that the public are aware of our progress, to continue to develop partnership working with our health and community organisations and include these when we consider commissioning in the future. And there was an addition made to the strategy from one of the consultation aims around being specific around working with our local area coordinators and social prescribers to support wellbeing through the enhanced networks that they have in their local areas. We're going to have an aim to continue to support carers and tackle digital exclusion, making contacting the right person as simple as quick as possible, develop our engagement and co-production. And there was a further aim which was related specifically to our Culture Leicestershire team. So from the consultation, the responses and the written responses will form part of our business planning over the next 4 years. And we're bringing it to you today to see if you had any further comments that you wanted to make as part of that consultation, whether you're happy with it, and any other comments that you may have.
Could you just turn your microphone off? Thanks. Any questions? That's quite okay. So I propose that the aims outlined within the strategy be noted. The comments now made by the board be submitted for inclusion in the consultation on the strategy. All in agreement? Thank you. Item 10 on the agenda is the Health and Wellbeing Board Development Sessions, which is on pages 215 to 223. This report provides an update on the evaluation of the development sessions that were conducted during 2024 to 25. Abby Vaughan, Health and Wellbeing Manager, will present the report.
Good afternoon, everybody. Thank you, Chair. So my name's Abby Vaughan. I'm the Health and Wellbeing Board Manager. I also coordinate the Staying Healthy Partnership subgroup and coordinate the design and delivery of the joint local health and wellbeing strategy. I'm just going to share my screen because I do have some additional slides in addition to the report that hopefully you've all read. Thank you. Those that come up there, brilliant. So really the purpose of this report is to provide an update to the Health and Wellbeing Board on the evaluation of the development sessions that took place during 24-25. And the board is requested to note the feedback from the development sessions. So thank you for everyone for attending them firstly, and for the feedback that you've provided to enable this report to be written. Note the recommendations and key themes that have come out of the sessions, and agree next steps for future Health and Wellbeing Board development sessions, including the timescales.
Okay, so during 24-25, we held 5 half-day development sessions for Health and Wellbeing Board members. These sessions were externally facilitated and were individually designed with key objectives, which I will explain later on in the presentation, and shaped by key stakeholders around this table here today, and responsible for delivering the life course priorities within the joint local health and wellbeing strategy. So each session can comprised of a blend of presentations, discussions and tabletop activities. So really to give you, Chair, a bit of an overview of why we have development sessions. It's to build leadership skills, improve our decision making ability in this group, foster collaboration between our partners, reflect on our priorities within the joint local health and wellbeing strategy, explore best practices and drive improvements in local health and wellbeing outcomes. So this slide highlights the sessions that were delivered under each life course priority and the associated objectives. So the Best Start for Life was really launched to identify what was working well in that partnership group and what could be collaboratively worked through to make progress on the joint local health and wellbeing strategy, identify any challenges, maximise strengths as well as opportunities. And I know that Jane's taken those forward in terms of the next stage of their review. The Staying Healthy partnership, Staying Healthy, Safe and Well. This development session really was to identify what was working well within the partnership and what the challenges were, including which priorities needed greater attention. The Integration Executive looked at 2 of our life course priorities, living supported well and dying well. So living and supporting well, the aim there was to share an update on the outcomes and achievements to date and agree the direction of travel for this priority during 25-26. And the dying well life course priority was to explore end of life, the current offer, its strengths and areas for development at system, place and neighbourhood level. And finally, our mental health place-based group, which delivers the cross-cutting priority within the strategy. That session was to provide an opportunity to understand patient and resident journey and review any overlapping priorities of other organisations to ensure alignment and prevent duplication within that area. Sorry, it slipped onto the next slide. So that was the slide I was just talking about there. So the next set of slides really just, we've already been given the recommendations within our report, so I'll just briefly skim over them here really. So the Best Start for Life agreed to prioritise the following areas during 25-26, really looking at the transferring of data across organisations, increasing that engagement with communities, working on development and recruitment and retention activity within the sector, and identifying opportunities for joint working, pooling of resources and improved engagement with the voluntary sector. So the Staying Healthy partnership recommendations from this session during 25-26 was agreed to spotlight a couple more priority areas alongside the existing remit for that group. So those 2 priority areas were the health and strategic planning system and healthy weight and food and nutrition. I've explained these before, they're in the paper, so I'll just skip over to the next slide. So the integration exec living and supported well during 25-26, the recommendations were to spotlight and focus on a few key areas, really focusing on prevention, the need to ensure the investment is in the right place, ensuring place-based needs are correct, targeting the right care at the right place, reduction in falls and frailty, focus on long-term conditions and promoting independence and self-management. And then in the dying well recommendations for 25-26, it was to cross-reference the place and ICB strategies and identify any gaps, identified what combined offers are possible, strengthen the links with children's services and the voluntary sector organisations, and align the joint local health and wellbeing strategy to the LLR strategic priorities. Form a reporting programme to Health and Wellbeing Board within this area and identify priority work streams to feed into the Integration Executive. And finally, the mental health cross-cutting group, the recommendations that were identified during 25-26 were to work on some of the challenges that they were facing, including the link between system, place and neighbourhood, the join up across all of our subgroups that sit under the board, and alignment of those priorities. Challenge the ways of working, help remove barriers across those organisations and navigate those complex structures. Engage meaningfully again with the voluntary sector, and look at strategic commissioning and review potential of joint commissioning and proactive early intervention and prevention. So all that feedback that I've just provided relating to those recommendations, there were some common themes that came out of all of those groups, and they were pooling of budgets and resources, including joint procurement opportunities, looking at the join up between our subgroups that sit underneath of the board. Patient involvement and active listening was highlighted. Data sharing was a prominent one across all of our subgroup conversations. Building resilience amongst communities and engagement and communication with communities. This one was also very, came up at most of our sessions, meaningful engagement with our voluntary sector, and looking at behaviour change across the partnership, looking at a systems approach and removing those barriers from working across different organisations. So the member feedback from the actual sessions was really positive. They were well attended, positively received, and most respondents stated that the sessions were either good or excellent. What worked well was listening and recognising the skill sets among our partners. There was a mix of group discussions and presentations, and it was externally facilitated, and I think that was really well received as well by our partners. There was a good cross-section of partners that attended all of our sessions, and this set of development sessions really did provide an opportunity to shape the focus and direction of our subgroups. So the takeaways are for going forward: ensure that we have group discussions, share knowledge with each other. We now understand a little bit more what other organisations are doing in each of our areas to help prevent that duplication. We'd like to understand more of our role of the voluntary sector colleagues that are sitting here as well, and we'll take that forward. And an understanding of the main work and priorities of the subgroup, which was defined, which is gained traction over the last few months, and the willingness for a system-wide approach, which was acknowledged by all of our partners. So there were a few areas of improvement highlighted, one being the output of development sessions to be turned into actions, and this will be actioned by through our subgroups and associated action planning and delivery planning on the back of this, and subsequent reports to board as well. Outcome focused and goal orientated, so these sessions were really focused on what do the subgroups need to achieve over the coming months and years, and future sessions will have more of a specific focus. Follow-up sessions to review progress, as I mentioned before. We will have a structured format to feedback up in our, through our subgroups as well as the Health and Wellbeing Board, and to improve our engagement as well. We need to ensure that if members can't attend specific individuals, if they do send substitutes, so that a wide range of organisations are represented at these groups, because they are really useful. A few suggestions were made for potential content for future sessions, including neighbourhood care and commissioning, which we've heard quite a bit about this morning, or this afternoon, I should say, sorry. Oral health, working with VCSs in our local communities, and strengthening public and patient engagement, to name but a few. So next steps really recommended to board are that the next sessions are held biannually, and they commence in 2026. The reason being, we do have potentially a Better Care Fund workshop that we would like to for our Health and Wellbeing Board members to be part of in the autumn. And we also have quite a heavy commitment of our members contributing to our joint local health and wellbeing strategy review. So we'd like to delay a future development session until 2026. And when that time comes, agree a specific topic area with that focus, taking into consideration what has been fed back in this report. Any questions?
Yeah, thank you. If you could just turn your microphone. Yeah, easy to forget. Yeah, any questions from anyone? Mike, yes, go ahead. Okay, Rachel first.
What's a gentleman, Mike? Thank you. More of a comment than a question, but what I want to do is just draw people's attention to the natural relationship between this work and the neighbourhood work that we've talked about earlier. And I think it's really important that as we go into developing those neighbourhood priorities, these priorities are reflected within that programme of work. I will work really closely with Abby and colleagues to make sure that that is the case. But I think that this work will absolutely give us a really strong foundation for those priorities within some of those neighbourhoods, and particularly as we go into piloting some of those MDTs and integrated neighbourhood team strengthening through the next few months. I think it's really important that these priorities are reflected within that work.
And Mike, go ahead.
Yeah, thanks, Chair. I was going to say the same thing. I think, we've had a couple of big things today where I know you haven't got the detail. The other one is ICB. Now, I know we'll get the updates at Health and Wellbeing Board, but I'd certainly value a development session on either or both of those, just to really kind of tease out what does it mean for this board and for place. So I'd agree with that one. If you were looking for one to knock out, though, Abby, I did groan a bit when I saw dentistry, because to be honest, it feels like we've been around the houses in Leicestershire and Leicester City and Rutland at scrutiny at Health and Wellbeing Board on dentistry, and it really goes anywhere, because it doesn't resolve the issue of there's just not enough dentists, and then we get into a discussion about oral health, which is fine. So I don't mind. From my point of view, I don't know what it would add, because I'm not quite certain what the end result would be. Whether that would free up time to then do a session on, say, the ICB changes, and we could talk that through in a bit more detail before Health and Wellbeing Board, then I'd advocate for dropping one and sticking something else in instead.
I just put everything down that was commented, because I don't want to leave anyone out really. But yeah, I think that discussion should happen a bit later on, so we could focus on what needs to be at the right time.
Any further questions? No. Okay. So I've got a question. It's, I suppose, a bit of a general question, but what support for neurodiversity is included in the strategy?
We have a health inequalities cross-cutting priority within the joint local health and wellbeing strategy, and particularly we're actually presenting an update from the Staying Healthy Partnership, and our focus has been on health inequalities, particularly focusing on learning disability health checks. So it's been covered through that cross-cutting theme, which all subgroups, the 4 subgroups, look at those inequalities as well. So yeah, it's covered quite broadly.
Thank you. I've got another question as well. I noticed in the integration executive, apologise if I've misunderstood this, but it says that 80% of the budget is used on a service which only 20% of people use. I suppose my question is what's gone wrong?
I think Rachel wants to take that question.
Yeah, shall I come on that? So I think what that reflects is some of the priorities, the reason why we are looking at this neighbourhood model of care, and this is around our people with the greatest level of need. A huge amount of our budget goes into those patients and people who have those PNG needs, of patient needs group of 9, 10, 11, and those highest areas of need. What we know is we reduce that cost by proactively working with those people and working differently with those people. So where we're talking about the highest cost at the moment being with that highest need 20% of the population, the whole idea of the neighbourhood programme is to reduce spend in this area so that we can increase spend and increase meeting need more proactively and more preventatively moving forward. So that is a statistic that we focus on quite a lot in terms of how we change that profile within our place.
Thank you. Any further questions? No. Okay, and we move on to the Better Care Fund, year end 2024-25.
recommendation.
No, we don't. Sorry about that. Okay, I propose that the board notes the feedback from the development session evaluations, notes the recommendations and key themes that came out of the sessions, and agrees next steps for future health and wellbeing board development sessions as suggested during the meeting. Everybody in favour? Thank you. We move on to the Better Care Fund year end 2024-25, which is in pages 223 to 255. This report provides the year-end performance reporting of the Better Care Fund programme for 2024-25. Lisa Carter, Health and Social Care Integration Manager, will present this report.
Thank you, Chair. Thanks for introducing me as well. Saves me the job. Okay, so periodically, for those that are new to this board, I bring reports on the Better Care Fund, which is a joint fund for social care and health services across Leicestershire. There is a similar corresponding fund for City and for Rutland. We have a statutory responsibility around delivery of these services within that, and we also have a statutory responsibility around levels of funding from health to cover social care services. This is primarily reported on through the integration exec, so that's where the governance goes for the Better Care Fund in its majority, and also links to delivery of part of the Joint Health and Wellbeing Strategy, which I'll come to in report 3 that I'll be going through today. So a bit like Rachel, it's the Rachel and Lisa show. Okay, so starting off with the year-end report for 24-25, I'll just take you through some of the decisions that we go through and some of the framework that we have that started in 2015. So we're sort of year 10 of the Better Care Fund. Every year we receive a framework, and it comes with a set of documentation that's approved by the Health and Wellbeing Board, and then we report on that quarterly as we progress throughout the year. All of these elements have timetables for decision making, and as part of the 24-25 year end, we had to submit prior to the Health and Wellbeing Board, but we generally tend to bring whatever we can, whenever we can, as long as it fits in with our governance timescales. For this report, this can go before we submit it, which is going to be the 6th of June deadline, but the actual 24-25 Better Care Fund in itself was pre-approved during that financial year. So that's just a bit of background. If you go down to paragraph 14, this details the income and expenditure. For 24-25, it was 83.2 million, which includes disabled facilities grants, which are passported to districts as well. In the table in paragraph 15, you can see how that funding's broken down. We have a contribution, a minimum, what's called the minimum contribution from the ICB into health and social care integrated services. We have elements, as you can see, for the disabled facilities grant and the IBCF, so which is the improved Better Care Fund. I'm going to come on to that in my next report because that's slightly changed for 25-26. For 24-25, we also had a discharge fund, which was separate to the BCF for 2.5 years, and that was largely for areas to focus on how to improve timescales around discharging people from hospitals, not just acute hospitals, but also community hospitals, mental health, etc. So that's how it was made up in 24-25. The metrics can be found at point 17. They are a set of 4 national metrics. It tells you what the target was for those metrics and what our actual outturn was, and some commentary about whether we're on target, off target, and how we're going to mitigate for some of that. As you can see, just briefly on the standardised admissions rate, we were over on our target, which I think we probably knew was going to happen probably about mid-year time in the year. For the percentage of people that were discharged to their normal place of residence, we're about 0.9% off target. So we're there or thereabouts for that one. Emergency hospital admissions due to falls, we've actually hit that target and we've done some really good work. We were off target for that for about 2 years. And we've actually pulled that back within 24-25 to be on target. So we've done lots of work, not just with people falling at home and being admitted, but also with care homes who regularly admit people due to falls, helping to reduce the amount of falling and also to help with care after a fall. Long-term support and people admitted into residential and nursing care home, that's also off target. Which is, I think sometimes it's very hard for us to predict where we're going to be with that metric because we don't know what the population, because it's a population per 100,000. So we don't know what the population is often when we set those targets. So I think we were quite over ambitious this year. So that will be taken into account once we've had confirmation of what the population element they're going to use nationally so that we can have a look at how we will fare this year, taking into account some of the facts that we were quite far off last year. Every year, the BCF comes with a set of national conditions. There were 4 in 24-25 plan. Jointly agreeing the plan, enabling people to stay well and safe and independent, right care, right place, right time, and maintaining that NHS national contribution, all of which we have met. The uplift for the ICB allocation for 24-25 was 5.66%. I'm going to mention that now because in the 25-26 one, that's quite drastically changed. We also have to do a piece of demand and capacity modelling work. So as part of the papers that come with this, you'll find that there is a plan template that we have to fill in that has the income, expenditure, demand and capacity, and information on metrics and how we've met all of those things throughout the year with small amounts of commentary within that. So part of that is demand and capacity modelling. It looks at how we think we are going, the amount of beds, people, services, spot purchase, domiciliary care. It takes into account all of that in terms of demand and ensures essentially that we've got the capacity to meet that. There are background papers, should you wish to read the planning guidance and the policy framework that sits behind the Better Care Fund. There's links there to that, but I'll close it there for the year-end template.
Thank you, Mike. You have a question?
Yeah, just a quick one. For our targets, and I've forgotten whether they are ours or whether other places have got them, but if we've got comparative data and we're off target, I suppose it begs the question of, let's assume we're off target, but is this a national thing or were we doing marginally better comparatively to other places or marginally worse? So
yeah, we always do have comparative data, and we tend to set targets comparatively with Leicester City and Rutland as well, because obviously with the ICB covering all 3 areas, it's got to be comparable. However, we do know where we sit sort of within those kind of, whether you're top quartile, second, third or fourth quartile, and we do try and tend to stretch ourselves. With that latter target, we do need to think about where we sit sort of nationally, because that has kind of dropped over the last couple of years. So we will take that into account. But, is there any point in setting a target you're not going to meet? So it's about making sure that the work programs that we've got in place are actually going to meet the targets that we set, which we probably need to do a bit more work on.
Any other questions? Anyone else? Yes, go ahead.
Yeah, it's just a little one really about the rate of admissions. Obviously, it mentions that investment in neighbourhood care should help to mitigate the increase seen. I was just thinking maybe, the impact of the neighbourhood care models might take a while to sort of come to fruition. So I wondered whether that's sort of taken into account for the target set for this year.
You'll see in the 25-26 plan exactly the numbers. So if you go to the 25-26 plan, where we talked about that mitigation, we've actually aligned the numbers to the activity. So for example, one of the things that we are looking at doing is revising our sort of falls service. So the falls response service, so not the proactive, sort of staying healthy led primary prevention ones, but where people have fallen at home and we have a response car. So what we've said is that we aim to reduce, I think, to get to where we need to get to, I think we need to reduce our admissions by about 75 people a month, which sounds really small, but we've kind of tried to break it down for 25-26. And we've tried to apply each of those to the activity that we're going to do. So, for example, expanding virtual wards and preventing admissions, expanding and working with intermediate care in frailty to prevent admissions unnecessarily from the frail cohort that are going through the SDEC. And if you look at the metric on that template for 25-26, it tells you exactly how we think we're going to do that through numbers, which is probably the first time we've gone into that kind of granular detail. I hope that's helpful.
Thank you. Any other questions? Councillor Bone.
Hi, how have you managed to reduce falls admissions to target? What work has been done with care homes and people living at home to achieve this? Thank you.
Thanks. So we've done quite a bit of work with care homes. So we looked at the, and this is probably a question for the care home subgroup, so they probably give you a more detailed answer. But the top 20, top 10, top 20 care homes across Leicester, Leicestershire and Rutland, so the care home subgroup is across LLR. Looking at the reasons why they're admitting, is it due to being risk averse? Is it due to equipment and actually being able to support people at home? Well, in their home, in their care home. So it's a range of things. So targeting those top 20, where you get the most amount of admissions and thinking about what they need to be able to support people at home, particularly if they aren't injured and they're just taken to hospital and they're conveyed to hospital and they're there for a bit of TLC for a night, maybe just one night, and maybe being looked after. It's about enabling those care homes to be able to do that within their own environments. It's about education. It's about having, so we have things like camels and elks, which are not actual animals, but they're kind of bits of equipment that actually help to ensure people aren't injured if they do fall out of bed. It's about having the right kind of assistive technology, so if they do fall, that people in the care home are advised straight away. So that's the kind of thing that's helped to reduce care homes admitting. We've also done some work with our provider for our falls car service, which we've got 2 cars, one that's based in Rutland and one that's based in Charnwood, and they rove if people have fallen, and there is a clinical response included in that as well. And we've actually increased the amount of people that they've seen within the last 12 months. So that's obviously also contributed. What they do is they go to people's homes, prevent long lies, which is why sometimes people, if they've laid quite a long time after a fall, they are much more likely to be admitted. So we've increased the amount of people that they've seen within the year as well. So they're the 2 things that have contributed directly.
Thank you. I understand Rachel from the ICB's got a question.
Yeah, not a question, but just kind of adding on to what Lisa's been saying around both the admission profile and around the falls. I think this is absolute testament to the work that is happening. So what we know is, in order to reduce admissions, we need to reduce attendances, but we also need to work internally around making sure that our ED department has access to all of those other community pathways. So it's as easy to send somebody to an alternative pathway as it is to admit somebody within your own organisation. And that's all part of the work that we are really focusing on, and making sure that we have the right presence in ED, and also the work that we're doing around our single point of access to make sure that things are going to a multidisciplinary assessment space, rather than just going to bed bureau and expecting that those patients will be admitted. So all of those pieces of work, I think, will contribute to hitting the target next year, and all of those things will be measured through the Neighbourhood Programme Board.
Thank you. Any further questions? Okay. One further question from me. Is there any work at the moment in terms of training carers to actually be able to assess people that have had a fall, and to make sure that they are safe and don't need admissions? Because I think a big problem that carers have is they don't know what they can and they can't do. And so almost by default, sometimes they will just admit people.
That's probably a better question, I'd say, for our integrated neighbourhood teams. So each of the team's neighbourhood plans would be able to tell you, probably through the Staying Healthy partnership, sorry Mike, but each of those neighbourhood plans will have areas of work that they're doing around falls and falls prevention, which is probably where this sits. You're absolutely right. Focusing on prevention is absolutely the right thing to do, and having carers able to do that, definitely. But within this kind of element of work, what we're doing is we're supporting people when they have fallen. So it's much more like a kind of a tertiary approach, rather than sort of like a primary prevention approach. We probably need to pick up on what Abby's just talked about, which is ensuring that we've got those kind of links between the different boards. So I think it's part of the integration exec. We should be having conversations with the Staying Healthy partnership to make sure that there is that primary prevention. But I can't tell you specifically, but I do know that district plans have all got falls services that help to strengthen people's cause. Whether they work specifically with carers, I don't know, but we might well do that as part of the carer strategy. John's going to answer that.
Thank you. John Wilson, please.
Thanks. Just to respond to your question, Chair. It is the case that if in adult social carers are advised not to lift people if they've fallen, unless they've had specific training in order to ensure that people are safe. Some carers will have had training. Some carers will have had training in particular forms of equipment, such as cameras and what have you. Others won't. And that's where interventions like the falls car, for example, are really important, because that allows for a clinical triage in order for the carer to know whether or not it's safe to lift the person. So a number of calls are made, and people do remain lying on having had a fall, simply because those carers are not fully trained or insured or clinically competent to potentially lift somebody in that situation. Having said that, it's not carers who admit people. And it goes back to the point that Rachel was making, really, which is that we need to avoid attendances. If we avoid attendances, we avoid admissions.
Yeah, I think just to pick up on that, one of the problems, again, with falls is if they are classed as a low priority, so a category 4 ambulance response, that tends to have emergency care assistants rather than paramedics, who won't necessarily be able to determine they're in the same position as the carers. So that obviously could reduce admissions potentially if carers were able to perform those assessments. But yeah, I'll move on. So I won't. Rachel again. Thank you.
Yeah, so just for awareness, that links into a piece of work that we've done this year, and in the last couple of months we've really focused on it. So any calls that go through to EMAS, our ambulance provider, if they are a category 4 or a category 3, then they are being diverted through to our home visiting service, which means that if there are longer waits for lower acuity patients in EMAS, they're being reduced because those calls are being diverted to an alternative provider.
Okay, Thank you. So I propose a motion. The board notes the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways in 2024-25. The year-end BCF 2024-25 template attached as the appendix to the report be approved for submission to NHS England for the 6th of June 2025 submission deadline. All in agreement? Thank you. The next report is the Better Care Fund Plan 2025-26, which is on pages 257 to 401. This report relates to the final Leicestershire Better Care Fund BCF plan for 2025-26. Lisa Carter will also present this report.
Thanks, Chair. So I won't go through some of the background to the BCF again, but what I will say is that I'll highlight some of the changes that have been made from 24-25 to 25-26. We don't always get a new BCF. Sometimes they run for 2 years, sometimes previously they have run for 3 years, and we do an in-year refresh. But this one is a full brand new plan, so it comes with a brand new set of policy framework and delivery and planning requirements. So in terms of the timetable for decisions, we have seen drafts because the planning and the policy framework were published on the 31st of January for 25-26, and they had an 8-week turnaround for completion for all areas. We were only able to previously bring to the Health and Wellbeing Board the draft submission and what we thought that was going to look like in terms of draft narrative plans and draft templates for returns. So this brings the full plan, but what we do if we haven't got the deadline aligned to a Health and Wellbeing Board is that it's signed off by the Chief Executive of the County Council on behalf of the Health and Wellbeing Board, and is approved by the ICB partners as well as part of that before it's submitted. So he uses the delegated powers to do that, and that was done on the 27th of March in order to submit prior to the deadline. So some of the changes for 25-26 that I'll just take you through. There are largely the same national conditions. There are still 4 of them. There's still one around jointly agreeing plans, but National Condition 2 has changed. It is about implementing the objectives of the Better Care Fund, of which there are 2 that are aligned to kind of overall NHS government policy, which is to support the shift from sickness to prevention and to support people to live independently, and the shift from hospital to home, which is very familiar to a neighbourhood model of care. National Condition 3, complying with grant and funding conditions, which is the same as previously. But National Condition 4 is complying with oversight and support processes, which is around engaging with BCF oversight and regionally led processes and enhanced oversight where there are performance concerns. Typically, we will have periodically through the year regional led groups, workshops, forums, etc. around the difference that the Better Care Fund's made, and we do that kind of with regional and national colleagues. So there is an oversight process, but there is also a timetable for reporting. Like I said, generally that's quarterly, and they will come with their own sets of templates, etc. to fill in, and they'll be reported here. As part of every BCF, prior to this, there is a strategic narrative that is part of the documentation that we've published today. That sets out the approach to integration and tells you how we're going to meet those national conditions. The detail in the narrative has been based on several discussions that we've had as part of the Health and Wellbeing Board. We have done as part of our joint health and wellbeing strategy sessions, we did talk about what we wanted to have included in the Better Care Fund and where we'd like that focus to be, albeit that was part of that joint health and wellbeing strategy process, knowing that I think it was on the same day that it was published, wasn't it? It was on the same day, so it was on the 31st of Jan. So it was a little bit of guesswork involved. Hence why this year we would like to have a workshop sort of later on in the autumn. We won't know what we have to do or comply with, but it's worth getting views of members and other board members and partners and other stakeholders. It's worth getting those views to be able to feed in at an earlier stage if we can. So we had a draft narrative come previously, and we've determined some of the priority areas and areas of further integration that we wanted to focus on in this year's plan. If you go to paragraph 21, it tells you that the income for this year is 84.4 million, so a slight increase from last year. Last year, if you remember, I said that the uplift was 5.66%. As you can see, that's vastly changed for 25-26. It's an uplift only to the NHS minimum contribution to social care of 3.9%, and then the rest of the NHS minimum contribution was uplifted by 1.7%. So that's quite a change to previous years in terms of increased spending. The other change that we've had is previously mentioned the IBCF, which is the Improved Better Care Grant, which is a proportion that is specifically for just adult social care, has been rolled in with the discharge grant. The discharge grant had two elements, a local authority element and an ICB element. So the IBCF has been combined with the local authority element, and the ICB element of the discharge grant, are you staying with me, has been rolled into the NHS minimum contribution. So that's just to give you a bit of background as to how things have changed finance-wise for this year. BCF metrics have also changed. We still have emergency admissions to hospital, and we still have long-term admissions to residential care. But in between that, sandwiched nicely in between, we've got average length of discharge delay for all adult acute patients. And there is a couple of areas that's derived from, which is proportion of adult patients discharged on their discharge ready date, and the average number of days from discharge ready date to discharge where they've not gone home on their discharge ready date. There are some headline metrics. There are some supporting metrics to those headline metrics as well, which there are 6 of those, and they support those, and they're all listed in paragraph 25. The ambitions for achieving the target metrics, we've kind of agreed again across the system. We had to do this before we knew what our 24-25 performance looked like. So we will be making sure that we kind of think about how we deliver against some of the targets that we had to make prior to our latest data, if you like. The ambitions reflect those changes in demand over the coming year. For example, we've looked at, again, going back to Ashley's point, we've looked at the increase in admissions, and we've thought about how we can actually reduce that in numerical terms with some of our schemes that we aim to deliver on. There are still the requirement to have intermediate care capacity and demand plans that projects demand for both step up and step down pathways, which is either before you go into hospital or after you come out of hospital, and a narrative explanation of how that flow works. We've also got plans in there around intermediate care and other short-term care, which forms quite a large part of our admission avoidance, and also ensuring that we discharge people in a timely way. All of that template has been included as an appendices to this cover report, along with a narrative plan, and the narrative plan itself has 3 appendices just to show a bit of information and give some examples to support what we've written about. Again, the links are at the bottom of the report as to where you can find your planning and policy refinements.
Thank you. Any questions? Okay. So I propose that the board notes the Leicestershire Better Care Fund Plan 2025-26, including the planning template, demand and capacity template and narrative document. And the board notes the action taken by the Chief Executive of Leicestershire County Council following consultation with the Chairman of the Health and Wellbeing Board to approve the BCF Year 25-26 report and use powers of delegation to approve this by the NHS England submission deadline of 31st of March 2025. All in agreement. Thank you. Yes.
Thanks, Chair. The other one, Lisa, was what you were saying about having a bit of a session to look at the next one in the way. Do we need to minute that? And would that be part of the Health and Wellbeing Board development sessions? It would be. Yeah. Okay.
Yeah, we're fully joined up.
Thank you. The board will now have a 5-minute comfort break. Thank you. Right, thank you and welcome back, everyone. Item 13 is the Joint Health and Wellbeing Strategy Progress Update on Living and Supported Well and Dying Well. That's on pages 403 to 416. This report provides an update on progress in relation to the Living and Supported Well and Dying Well strategic priorities of the Joint and Health and Wellbeing Strategy 2022 to 2032. This report will be presented by Lisa Carter.
Thanks, Chair. So yeah, just moving on to this report, I think Abby's kind of covered a lot of why we annually look at how we're delivering against our elements of the strategy. This section, it focuses on what we've done against living and supported well and dying well over the last 12 months. That is governed through the integration exec and the integration delivery and commissioning group, the integration exec chaired by Nikhil. If you go to the template pages that show you what we do as part of our programme plan, is align every action and activity and scheme, including those within the BCF, to our joint health and wellbeing strategy priorities. So there's a real golden thread between understanding what we're spending our BCF on, how it's delivering against living and supported well, what elements it's buying, what it's paying for, and then how it's governed, etc., and how it's delivering against some of those commitments. So as from those can't see what page it is. On the second page of the report, your third page of the report, where the green templates and tables start, you can see the activity that we've picked up on. This isn't all of the activity, by the way. There are 98 lines in the BCF, which form most of our delivery of staying, of living and supported well. So we haven't listed them here. We've kind of cherry picked some examples. And it's taking you through some of the activity, what that detail, what the activity does and delivers against, how many beneficiaries there have been, the investment, which mostly comes from the BCF. There are a couple of areas that come from core funding, and the commitments that they deliver against. So that is on the first two pages of the tables. You can see that we've got some really good areas of work, and you can see how many people that those areas and those schemes kind of reach throughout the 12 months of the year. Priority 2, exactly the same thing, is the effective management of frailty and complex care, which is a sub-priority of living and supported well. Again, takes you through exactly the same way, the kinds of things that we are delivering against for that element of the strategy. Living and dying well is slightly different. Dying well is much more of a kind of partnership approach, because we don't necessarily directly fund it and we don't necessarily directly commission those services. Within the council, for example, we deliver services based on people's needs, and not necessarily specifically for kind of palliative care, etc. Whereas our health colleagues do a lot of the commissioning and design of those services. So what we've committed to do is to be part of the work streams in development of the new strategy around end of life, and it tells you the kind of things that we've had as key interventions, and which of the work streams, there are 7 work streams of part of that programme of work, which of those work streams is picking up on those interventions, and you can see where those interventions align to our joint health and wellbeing strategy commitments. So that's the next couple of pages. We've also done a piece of work on the cross-cutting priorities of the joint health wellbeing strategy, so you can see how we've contributed towards improved mental health and reducing health inequalities as part of the programme of integration that we do, and where we've made investment and how many people that have benefited from some of those areas. We've also I've kind of collated some of the areas of really good performance that we've had over the last 12 months to show you what a difference it's made, because a lot of the time we do talk about the so what. So what are the outcomes of that many people and that much of investment receiving some of the integrated schemes that we deliver. So in paragraph 12, you can see in a set of bullet points where we've made some really good areas of performance improvement. 13 highlights some of the challenges that we continue to experience. A lot of that is linked to ever increasing demand, not just for social care services, but for health services as well. Admissions, we've already talked about. Challenges around staff meeting demand, because I think sort of universally, we have funding for staffing, but we've not been able to recruit to the levels to meet some of the demands in some of the areas that we want to improve on. And primary care access remains a challenge. It's in a similar vein. Demand outstrips capacity in some areas. So what we're going to do over the next 12 months, we are going to focus on the services moving closer to communities. We've already talked about the emerging neighbourhood models of care. It runs all the way through the 25-26 BCF as well, and it tells you the level of investment that we've had. Step Up Care will be the focus of the intermediate care programme. Last couple of years, it's largely been focused on step down. So coming out of hospital, now you want to do some really good work and make some really good inroads into Step Up. Proactive management of demand, which is around, again, that proactively identifying people to ensure that you've got services in the right place to prevent that kind of burning platform. And looking at bedded care requirements, particularly within 25-26. We know we don't currently meet the need for discharge to assess bedded requirements. So we'll be working on that throughout the year. And that's it for that one. Oh, and just one more thing on the 25-26 plan for BCF. We have had across Leicester, Leicestershire and Rutland approval from the Regional Better Care Fund teams that they have all 3 plans have been approved for this year, and that's the recommendation to the national team. So it goes on to national approval.
Thank you. Are there any questions? Oh, Rachel, go ahead.
Yeah, sorry, and not so much a question, but a comment, and that's around the kind of data that we gather around this stuff and the sophistication of the data. So what we are doing is we're working really hard on our understanding of the data. So what that's showing us is a way to kind of also manage expectation around the different schemes that we're working through. So whilst we are still seeing that increase in admissions, that increase in admissions isn't necessarily within the cohort that this group are working with. Actually, those admissions have remained relatively stable. Where we've seen the greater increase in admissions has been from younger people with different needs. So we do need to be mindful as we're doing this work that we connect the dots in terms of the outcomes of this piece of work, but also the data needs to be much more broadly spread for us to really understand where that element of need is and what we need to do differently, actually. So just around that sophistication of data, I think it's a really important point.
Thank you. Are there any other questions or comments? Okay. So I propose that the board notes the progress being made in relation to delivering against the Living and Supported Well and Dying Well strategic priorities, and notes the progress being made in relation to delivering against the cross-cutting priorities. All in agreement. Thank you. Our final report is the Joint Health and Wellbeing Strategy Process update on staying healthy, safe and well, which is on pages 417 to 432. This report provides an update on progress in relation to the staying healthy, safe and well priority of the Joint Health and Wellbeing Strategy 2022-2023, and the report will be presented by Mike Sandys, Director of Public Health.
There you go. Thank you, Chair. I've got a presentation of about 40 slides, which will take me an hour and a half, and then maybe we'll allow an hour for discussion. Failing that, it's the same report that Lisa's just done on progress on the strategy, but this is about progress on the staying healthy, safe and well priorities, as you were saying, Chair, that are taken forward on behalf of the board by the Staying Healthy Partnership, one of the 4 subgroups of the Health and Wellbeing Board. As Lisa was saying, Abby's covered a little bit of this in a piece on the development session, so I won't dwell. But you can see in the report there's been a large amount of work done by the Staying Healthy Partnership in relation to those 2 key areas: building strong foundations, so what we're doing working around housing, healthy policy work, for instance, and then the other big thing for us is enabling healthy choices environments, with cross-cutting things where we've done some particular work on supporting people in temporary accommodation, upping the uptake of learning disability health checks, and then also work around women's health. So hopefully all straightforward, as I say, those page 419 onwards gives a good idea of where we have tried to embed health in all our decision-making policies, both in the county council and in our district council colleagues. A deal of initiatives going on around health and work, such as the Work Well initiative that the NHS leads, and indeed within public health, our own health workplaces programme, where we go out and do health MOTs with staff. Other things I would highlight just on that kind of long list, particularly very keen on the Housing and Respiratory Illness Project, where we are working collaboratively with district councils, EMAS, and others, just looking at kind of indoor air quality and damp and mould and addressing those. That's been quite a good feather in our cap. The amount of money that is secured through district council colleagues to put in place energy efficiency measures, which make a reduction in fuel bills to our less well-off members of Leicestershire, and then a deal of work around healthy choices, working on a whole systems approach to healthy food, which isn't then just tackling kind of overweight and providing weight management services, but addresses things like farm food insecurity, working through kind of air miles or food miles, all those kind of things, which has spin-offs, I think, really just in terms of tourism. We think about Melton Mowbray and pork pies, and food industry, as well as being good for people's health. So a lot in there, but I won't dwell on them in particular. But any questions that people might have, happy to have a go at answering them. There you go.
Yes, are there any questions to that? Yes, go ahead, Abby.
I was just going to direct you to the slide that we're sharing. You mentioned earlier about what we're doing in terms of neurodiversity and health inequalities, and we do have a bit of a slide that is related to the report, and that's the work that we've really been focused on, hasn't it, over the last 12 months? I don't know if you wanted to add anything on that.
Yeah, it has been. I mean, again, we did a variety of work working through partners, just you were saying. I guess I'm looking at Jane, because I suppose the work that we did in Staying Healthy Partnership around raising the uptake of learning disability health checks is a very, very small part of work that goes on across the system on neurodiversity. But I don't want to stitch you up with a half-hour presentation. Having said I won't do one, but it's probably worthwhile just talking a bit about that.
Yeah, I think and a lot of this won't appear here around the work on the neurodiversity pathway, but the neurodiversity pathway is obviously led through our colleagues in LPT, which does look at well, particularly for children, and how we ensure that children's needs are both identified and then met. But certainly the work led through the Learning Disability Partnership and Neurodiversity Partnership focuses on that pathway, and therefore the services that come out of that.
Thank you. Are there any further questions? Okay. So I propose that the board notes the progress being made in relation to delivering against the Staying Healthy, Safe and Well priority, notes the progress being made in relation to delivering against the cross-cutting priorities. All in agreement. Thank you. Agenda item 15 is the date of the next meeting. The next meeting of the board is scheduled to take place on the 25th of September 2025 at 2 p.m. Agenda item 16 is urgent items. There are no urgent items on the agenda. This is my first meeting as chairman. Thank you for your patience and for your attendance. I'll now draw the meeting to a close. Thank you.